Emeritus, Department of Shalatantra, SDM College of Ayurveda, Udupi, to take over the session. Welcome, sir.
Next is about the disease of the intestines. Among the conditions related to the intestines, intestinal obstruction is the one which is quite significant. It is also considered as one of the acute emergency condition. Obstruction means any of the situation where the contents of the intestines are not able to pass through or they have become stagnated. And it can be of either a mechanical obstruction or it could be simply functional. Functional or what we call as a paralytic ileus. So paralytic ileus in the sense where the peristalsis movement has become stopped and hence the foot cannot move, and hence that also is considered as obstruction. Or of course some texts would name that as a pseudo obstruction. That's one of the classification of the obstruction. The other way of obstructing this classifying the obstruction would be either as a small bowel obstruction or large bowel obstruction, small intestines and large intestine obstructions, where there can be slight differences in the clinical presentation as such. And of course, the prognosis and outcome also are slightly different. And in addition to that, the other way of classification will be dynamic and adynamic obstruction, a point which we will come to that. The causes for the obstruction are many. They could be classified as causes which are outside the lumen of the intestines or the peritoneum, or which are on the lumen of the intestines, and intraluminal conditions which are present within the lumen. So among them, from the clinical incidence point of view, the most common are the adhesions. A patient who had undergone any surgery earlier or due to some other inflammatory pathology like tuberculosis of the peritoneum, heated or even Crohn's disease like conditions, there could be adhesions between the peritoneum and the intestines, and due to that adhesions between the peritoneum and the intestines, loops of the intestine may become immovable or rather curved as such, and hence there could be an obstruction. That's the rather more common cause of the obstruction. The next cause for them could be the hernia, internal or external hernia, where the loops of the intestines are protruded and hence they will be blocked, and particularly at the neck of the hernial sac, back as the intestine loops are doubled up. That's the situation where the obstruction tends to occur more frequently. Then the neoplasm, different variety of new malignancy, both intestinal as well as extraintestinal. Rather more commonly extraintestinal pathologies, lesions of any organs in the viscera. Malignancies can be producing adhesions in both the ways. Either it could be the mechanical effect of the mass, or it could be due to the adhesions formed. Then inflammatory diseases like Crohn's disease also can produce obstruction. Gallstones, they produce a very typical obstruction called as gallstone ileus. Gallstones are formed in the gallbladder and they may get expelled out into the intestines, and in the intestines they may grow further due to the addition of the food substances over the area, and these grown gallstones can produce obstruction within the lumen, and they produce a partial obstruction. See, once there is an obstruction, there will be a dilatation of the loop proximally. In a gallstone which is present over there, where in the gallstone ileus, it may just fall back and then produce a partial or recurrent obstruction conditions. Malrotation, congenital pathologies, where the loops of the intestines are rotated abnormally, or malrotation also can occur as a consequence of the serious surgery. Cysts in the intestine, lumen of the cysts in the peritoneum also can produce obstructions. Inflammatory disorders like diverticulitis or tuberculosis or the parasites in the intestines, particularly worms. Worm ball obstruction is a established entity which is quite common in a pressure space occupying lesion like a hematoma. Then strictures, another important are the stricture. Due to a previous inflammation or maybe the ischemic conditions, the lumen of the intestine may become narrow and that can produce obstruction. Intersusception and volvulus, these are the other two conditions where there could be intersusception where a loop of the intestine gets protruded into another lumen, valgus where it gets twisted, the loop of the intestine may get twisted as it, are endometrial cyst-like conditions where the endometrial tissues present in the abdomen viscera, they may get swollen. Radiations also can, radiation done for the treatment of malignancies and presence of the foreign words. Of course, as far as the causes are concerned, both large bowel obstruction and small bowel obstruction, the causes are almost similar, but as the clinical presentation is different, we consider them as the two entities. Now, once there is an obstruction to the flow of the contents, the next of the situation or pathological changes will be there will be accumulation of the gas as well as the fluid sequestration. See, normally the fluid which is secreted into the intestines would be from the secretions of the intestines as well as whatever you consume as the food, and then gradually it gets absorbed. In case of an obstruction, there will be obstruction, this absorption will be blocked and there will be no more absorption. And as the intestinal loop gets distended, the distension of the proximal loop of the intestine is one of the important issues. And as it gets distended, there can be a reverse osmosis. Instead of the fluid getting absorbed from the intestines, there could be leakage of the fluid from the body into the intestinal lumen, which again produces increase in the quantity of the fluid. Now, gas formed in the loop is due to the fermentation along with the normal contents of the gas. The food gets fermented because of the stagnation, and both this gas and the fluid will further add on to the volume, and hence the distension continues to increase. Once there is an obstruction anywhere, the body would be trying to get over the obstruction by increasing the peristalsis. So initially there will be an increase in the peristalsis, and it is an attempt by the body to get over the obstruction. Suppose the increased peristalsis is able to relieve that or push the contents across the obstructive loop, then the condition would become normal, the patient would recover. If it fails, then it goes into a vicious cycle. There would be further accumulation of the fluid, further distension, and that distension can produce a ischemia, blockade of the vessels, particularly the venous congestion would occur first, then the arterial. When the venous congestion would occur, or the venous obstruction occurs, there would be more and more leakage, and when the arterial obstruction occurs, it results in a necrosis of the loop of the intestine. So it may produce a necrosis or non-viable loop of the intestine can occur, and this may get perforated, or that it may get infected. Infection may spread into the peritoneum, and widespread complications can occur. So the whole course of the pathology of an obstruction, irrespective of the cause, would be there could be endoluminal gas and fluid accumulation and the digestive secretions, the same which I have just discussed, and results in further hypersecretion, and this results in inhibition of the absorption of fluid and electrolytes, and it also produces disorders of the parietal venous outflow, edema and congestion of the abdominal wall also can occur. Then parietal ischemic phase would occur, there will be ischemia as such, and this results in the permeability of the wall of the intestines, and bacterial flora will be changed. There will be both of anaerobic organisms, and the growth of aerobic organisms will be reduced. There will be significant changes in the electrolytes in the body. Electrolytes like sodium and potassium chloride will be depleted as such, and it results in a hypovolemia. There will be leakage of the fluid from the body into the lumen, and hence it results in hypovolemia, as well as the electrolytes will be changed, and hence it results in insufficient renal perfusion also later on, and exotemia or even hemoconcentration occur. As the fluid is lost, the hemoglobin level tends to rise because it becomes concentrated, volume of the blood becomes reduced, but cellular elements will be the same, and hence there will be concentration. It also results in tachycardia, or central venous pressure will be reduced, cardiac output will be reduced, and it can result in a hypovolemic shock. The intestinal gases which are formed in the abnormal conditions, like a fermented condition, the hydrogen disulfide, a product of fermentation, which enhances very rapidly. methane also increases. In the normal conditions, the methane and hydrogen sulfide would be a lower percentage, 1 to 10%. But in case of an obstruction, their percentage increases. And methane and hydrogen sulfide also are toxic to the visceral, toxic to the neurological nervous system as such, and it enhances chances of a paralytic areas. So every obstruction at the end, if it is not treated early, can result in a paralytic areas. In the whole configuration of the intestinal gases, in the normal situation, there would be 70% of nitrogen and 10 to 12% of oxygen, whereas these toxic gases would be 1 to 10% as such. In case of an obstruction, they increase, and that inflames the nerves, and the functions of the nerves will be affected remarkably, and that's why the paralytic areas would occur. The digestive volume, the secretion of the digestive secretions, volume of the digestive secretions per day is around 6 liters, like say saliva 1500, gastric secretion 2500, bile 500, pancreatic juice and intestinal mucosal secretion, a total 8200, something around 8 liters per day. That would be the normal asset, and the plasma volume is 3500. In a case of obstruction, this increases and it may double or even triple. Instead of 8,000, it may even go up to 24,000 ml, which would be very huge, and that results in the distension of the loop as well as distension of the abdomen. The clinical signs and symptoms are nausea and vomiting is seen in 60 to 80%, and nausea and vomiting would occur early in case of a proximal obstruction, proximal loop, like the small intestines as such. Whereas in the distal intestinal obstruction, large intestinal obstruction, nausea and vomiting occur would last the late symptoms. So in case of small intestinal obstruction, more than 80% of the patients would come in with the start with the symptom of nausea and vomiting, and initially the vomiters would be always bilious, and it will be a forceful vomiting as such. And another characteristic feature is the vomiting always precedes a colicky episode of pain. Patient would have a colicky pain, and at the end of the colicky pain, the patient may vomit out. Once there is vomiting, temporarily the pain may get reduced, and again there will be another attack of a colicky episode. Characteristically, if the obstruction is progressive, the duration of the colicky pain enhances, gap between the two episodes of the colicky pain gets reduced, and this quantity of the vomiters also would be continuously increasing. See, vomiting in case of acute abdominal conditions can produce in inflammatory pathologies like appendicitis or cholecystitis, etc., where there will be reflex vomiting. Whereas the vomiting produced due to obstruction and this reflex vomiting would be, the difference would be, in case of the reflex vomiting, the initial vomiters quantity would be more, but later on the vomiting vomiters content would be reduced, and even there could be a dry vomiters or dry vomiting, like or retching, where the patient may attempt for vomiting, but he may not vomit out any of the substances. Whereas in case of the intestinal obstruction, the situation is different. As the patient vomits frequently, the consequent vomiters would have more and more quantity. The quantity tends to increase by every act of vomiting, and instead of containing the food, later on it will be only the intestinal juices or bile which could be presented in the vomiters. So clinically, this kind of a history of a colicky pain followed by the vomiting and gradual progressive increase in the vomiters is a characteristic feature of a particularly proximal intestinal obstruction. And the location of the obstruction, if it is more close to the duodenum, the vomiting would be early. As it goes beyond, the location of the obstruction goes distally, the time taken for the vomiting would be increased. Later on now, as the colicky episodes and that interval becomes reduced, at one stage there could be a situation where the patient may have constant pain and the vomiters become effortless, vomiting becomes effortless. And this is a situation where the patient has resulted in a adynamic obstruction, and we classify the obstruction into the two phases, dynamic and adynamic. Dynamic is that stage where the body is attempting to get over the obstruction by increasing the peristalsis. And during that stage, due to that increased peristalsis, the patient would have a colicky pain, and then it may, if it's not able to get over the obstruction, the contents will be pushed out in the form of vomiting. And later on, if the body fails to get over the obstruction, it results in a failure of the peristaltic veins due to the same toxic issues and the dilatation of the intestines, and it results in a constant dull aching type of the pain. The intensity of the pain gets reduced. As the intensity of the pain gets reduced and vomiting becomes effortless, many times it may lead to a misperception in the clinical condition, clinical practice. Like you may feel that the patient is improving, but it's not a sign of improving. A reduction of the pain in case of intestinal obstruction is not always a sign of clinical improvement. This fact has to be kept in mind. Of course, if the patient is relieved, the pain will be reduced. But in a case of these paralytic ileus, it may be a constant pain where the intensity is reduced, and hence the patient may say that the patient is relieved. Then another very common clinical symptom is constipation or obstipation. The word obstipation is where the patient is not passing the stools as well as the bladders, and this is seen in around 90% of the conditions. Again, in a large bowel obstruction, the symptom of obstipation occurs quite early, whereas in case of the small intestine obstruction, it may take some more time. In the obstructions produced due to intersusception-like conditions or gallstone ileus conditions, patient may continue to pass the stools, the platters also may be passed through, and there may not be an obstipation symptom. So, obstipation symptom is a rule in case of intestinal obstruction produced due to other conditions than the intersusception or the gallstone ileus. Reasons are simple. In the intersusception, there will be a mucosal discharge which you call as the red currant jelly stools, whereas gallstone ileus, because of the possible movement of the stone into the proximal loop, the patient may continue to pass the stools. Distension of the abdomen is very characteristic. Fever, tachycardia also may be late findings and may be associated with the strangulation. So, in that patient has a fever, it could be a sign of strangulation. That's the ischemia developing over here. Barborhythmy, a loud peristaltic sounds are seen in the are heard in the early stage. The word barborhythmy, the meaning is lion roaring like sounds, and that lion-like sounds could be heard even without the stethoscope in a patient of obstruction. Visible peristalsis is another of the clinical sign. The visible peristalsis may be observed better in children or the patients who have a relatively thin body wall, but in an obese patient it may not be seen as such. Now, a patient with the intestinal obstruction, if the patient has a history of previous surgeries or pelvic or abdominal surgeries, previous radiation therapy, or history of malignancy, or if the patient has inflammatory bowel disease history, that condition would be more risky, and patients with intestinal obstruction symptoms with these histories, they have to be taken more careful as such. Now, I have referred to that dynamic and adynamic stages of the obstruction. That same issue which you have discussed, classified in a manner, summarized manner. The history of dynamic obstruction is patient would have a previous history of abdominal or pelvic surgery or so on, whereas adynamic, every risk factor of dynamic obstruction with maybe a reflex paralysis. There could be a paralysis changes also. Along with that, the causes of the ileus, which we discuss later on in detail, we will discuss that ileus separately. The causes of that also may be seen. Pain characteristical in the dynamic stage, it is colicky, whereas in the adynamic stage, either absent or maybe mild. Vomiting, of course, is present, but in case of dynamic obstruction, the vomiting is a efforted vomiting or this forceful vomiting. It's projectile vomiting, whereas in case of adynamic obstruction, it's effortless vomiting. Abdominal distension, of course, is present in both the conditions. Most of the times, in case of the dynamic obstruction, the distension is seen with only gaseous distension. That's why when you percuss, it will be resonant throughout. Whereas in aerodynamic obstruction, there is a chance of some areas of dullness in between that resurgent areas. Zones of dullness could be seen either due to the loops of the intestine which are filled with the fluid, or due to the leakage of the fluid into the peritoneum, you may see the presence of the dullness. And observation or flatus as well as bowel movement being absent is seen in both the conditions. X-rays would help you to make out the diagnosis. The most dependable means of making the diagnosis of intestinal obstruction is the plain X-ray, and it's always better to have the X-ray in an erect posture so that the levels of the fluid can be made out. Now, depending upon the stage of the obstruction, the clinical signs which we see, the radiological signs which we see could be, in the initial stages, it will be only the dilated loops of the intestines. The loops of the intestines would be dilated, and there could be absence of the gas shadows in some areas. See, distal to the area of obstruction, there will be absence of the gas shadow, whereas in the proximal area, the loops will be dilated. In the later stages, you will see the fluid levels, horizontal fluid levels could be seen. Presence of the horizontal fluid levels is a sign of aerodynamic obstruction. So, you may identify these loops of the intestines. Diameter of the loops of the intestines also can be measured. The broadest of the loop of the intestine is the close to the level of obstruction, and as it goes proximally, it becomes gradually thinner. Though it's dilated, it becomes thinner. Distal loops of the intestines are usually blocked, and hence there will be no gas shadow seen. That's the important issue. Fluid levels are very characteristic. In addition to that, certain of the conditions that we may see a string of pearls like sign. This is a typical radiological term used, where the loops of the gases or bubbles of the gases which are present in between the loops of the intestine seen along with the fluid levels, it looks like a string of pearls. That's the appearance given radiologically. Now again, the same issue in the three stages of the obstruction: early stages of obstruction, then advanced stages of the obstruction. A typically dynamic obstruction, you will see the peristaltic veils, and the constriction of the peristaltic veils will be visible. Gradually, the loops of the intestine becomes more characteristic, less like a smooth pipe-like appearance. Then the fluid levels. Number of fluid levels also could be considered as one of the criteria to suggest about the severity of the lesion. That's the utility of the plain X-ray. CT image is now considered as the benchmark for the diagnosis of the obstruction, because with the CT image, many times the cause for the obstruction can be made out, as well as the exact location of the obstruction also can be made out. The characteristic feature of the constricted loop, the location of the obstruction, the proximal distal constricted tubule, and the loop, and the proximal dilated loop, that can be made out. And many times, if there is any external cause of the obstruction like a mass, that also can be made out with the CT scan, and hence in the diagnosis of the intestinal obstruction, CT scan is considered to be better than the plain X-ray. Ultrasonography, of course, is also another of the choice of the investigation, which gives you an idea about the dimensions of the loop of the intestine correctly, and the thickness of the walls of the intestines, whether the walls of the intestines have become edematous or whether they are strangulated or not. Particularly the risk of strangulation, when there is a ischemic changes there, that ischemic changes can be better made out with the ultrasonography. So, choice of the investigation will be depending upon the status of the patient. Now, the management, principles of the management of intestinal obstruction, there is a paradigm changes compared to what was present in 1980s earlier, and the present day situation. In the earlier this approach, intestinal obstruction, there was a general rule, clinical rule, that no obstruction could be left over for overnight, or obstruction is not supposed to see two sunrises or two sunsets. This is what the earlier dictum was, like you should not wait beyond 24 hours. Conservative treatment should be done only for 24 hours. But the situation now is different. The latest guideline is you can continue the conservative approach up to 72 hours for 3 days. Selection of that patient would be, the first is whether the patient is clinically stable or not. If the patient is clinically stable, the conservative management should be followed, and follow up the patient. Like, as long as the patient, if the patient is able to pass the platters and stools, that's a sign of recovery. The sign of recovery is not willfully, but it's about the passage of the platters of the stools. One of the important parameter to monitor during the management of the obstruction is abdominal girth. Abdominal girth should be measured at three levels: at the subcostal level, and that's the lower end of the ribs, then umbilical level, and at the pelvic, superior pelvic, iliac crest level. You have to measure the girth, and this girth has to be followed regularly. If the girth is reducing, that could be a sign of improvement. If the girth is increasing, that could be a sign of worsening. So that's other parameter by which you have to follow the patient. If the patient is not clinically stable and there is a sign of necrosis already, then you are not supposed to go for as early as surgery. Emergency surgery has to be done if the patient is known to have obstruction, and if there is a clinically unstable condition and if the obstruction is for more than 72 hours, then exploratory laparotomy is a choice asset. If the patient is stable, then you have to go for the investigations, complete radiography, and maybe CT asset. If there is a evidence of vascular compromise, as in case of either the GSD image or maybe the CT image, then surgery is to be done. If there is no sign of vascular image, you may still continue to maintain the patient on the conservative management. The conservative management principles are nothing: nil worry, nasogastric intubation, continuous drainage of the content from the stomach. It's not the intubation alone. Through the tube, that nasogastric tube, continuous drainage of the contents, and fluid and electrolytes as well as nourishment has to be maintained parenterally. So IV fluid, this is a basic protocol of treatment of an intestinal obstruction. In addition to that, another course would be antibiotics. Antibiotics to reduce the chances of the secondary infection. Now, if there is a complete obstruction, even then, without vascular stasis, you may be and continue the management. And if there is a partial obstruction, again the same management as done. If these obstructions are relieved within 24 to 48 hours, of course the latest is 72 hours, then there is no need of exploratory laparotomy, and then gradually go for the diet, advanced diet in a sense, gradually step by step increasing the oral intake and maintaining a IV support till the patient is able to have a proper nourishment through the oral route. If not, exploratory laparotomy done. The exploratory laparotomy involves the opening of the abdomen, then you will have to search for the location of the obstruction, and the loop of the intestine which has become obstructed has to be examined. Then, if the loop of the intestine is having a ischemic changes, you will have to confirm whether that loop is viable or not. The viability of the loop is studied by one its appearance and the vascular response. If you put a warm swab over the loop of the intestine, see if that warm swab results in a change in the color or not. See, in a case of viable loop, it may look black in the initial, but when you put a warm swab or when you have decompressed the proximal loop, the color may get re-established. The next part is about the proximal loop has to be decompressed. That contents, the dilated loop has to be reduced in size, either by making a small opening here and then draining it out, or it may be squeezing it proximally further. So the proximal loop has to be reduced in the reduction of the size is important, and the contents have to be removed as such. Then the next is lavage. The peritoneum has to be cleaned thoroughly with the saline, and then the abdomen has to be closed. That's the protocol of treating the surgery as such. In the patients with the small bowel obstruction, it's always preferred to have a non-surgical approach or non-operative approach. The guideline for the non-operative approach is if the patient has a malignant tumor and obstruction is usually due to the metastasis, then it's always preferable to, as far as possible, maintain the patient on a non-operative procedure, because the outcome of a surgery would be poorer. In the patients who have inflammatory bowel disease like Crohn's disease, it's preferable to maintain the patient on the conservative management along with the rigorous treatment for the inflammatory bowel pathology. Like if the Crohn's disease, the specific drugs for that condition. If it is a colitis, ulcerative colitis, that also has to be done. Because if the surgery has to be done, it results in a bowel resection, significant bowel resection, and the complications also will be more. And hence, in these conditions, it's always better to keep the patient on conservative management. Another, if the patient has intra-abdominal abscess, which has resulted in obstruction, then again, instead of going for a laparotomy, a CT-guided drainage is usually sufficient. So there is no need of a laparotomy surgery. In the patients who have obstruction as a result of radiation, which is also called as radiation enteritis, and if the patient has developed that obstruction symptoms within a short period of radiation, then a non-operative treatment with the steroids is usually sufficient. Steroids are indicated. Hernia, incarcerated hernia, where the hernias are loops of the intestines are there. Most of the times, elective hernia repair is to be done. Manual reduction and observation is always a better choice. But if at all you have to do the hernial surgery, there again the loop of the intestine has to be examined for the viability, and then only the viable loops have to be saved, otherwise that has to be resected. If the loop has become non-viable, that has to be resected and end-to-end anastomosis is done. If the patient has developed obstruction immediately after the surgery, acute postoperative obstruction, the diagnosis is always difficult, and often it could be due to the paralytic ileus developing after the surgery, and hence it's always preferable to have the conservative management. So these are the other guidelines to keep the patient on conservative management. And in the patients of adhesions, we will have a different detailed description of the adhesions induced of intestinal obstructions next. The complications of the intestinal obstruction also depend upon the severity of the condition, patient's age, presence of other comorbidities, and the duration of the symptoms and signs. And they are non-viability of the loop, or the whole loop becomes gangrenous, which I have referred to, sepsis, due to the intestinal bacteria being changed out, and they may even result in a shift of the bacteria into the peritoneum as well as the system. Intra-abdominal abscess could be a complication of the intestinal obstruction. Wound dehiscence, post-operative, particularly if the obstruction occurs, the wound may get dehisced. The vomiters may get aspirated, and the patient may have an aspiration pneumonia, and then all the complications. If the patient has undergone surgery and the dissection of the loop of that intestines have occurred, it can result in a shock bowel syndrome. That's dissection of the loop may result in situation where the absorption becomes reduced, or it can result in a disability and death due to the secondary complications. That's in general the general principles of the treating with the obstruction. Now coming to the specific, certain of the specific varieties of obstruction based upon the clinical importance. One of that is, as I said, adhesion-induced bowel obstruction. In the adhesion-induced bowel obstruction, the most important dependable diagnosis will be CT scan. CT scan is the one criteria by which the adhesions can be confirmed. See, when a patient presents with the signs of intestinal obstruction, to identify the cause of the obstruction, whether it is due to the adhesion or otherwise, is often difficult. If the patient has a history of previous surgery, if the patient has a history of radiation, if the patient has a history of abdominal inflammatory disorders like Crohn's or tuberculosis, then we may have a probable diagnosis of obstruction, but a probable diagnosis of adhesion-induced obstruction. But we are not sure about it. To confirm, CT scan is a better tool of investigation to confirm that adhesions-induced obstruction. And in such conditions, non-operative management can be prolonged for up to 72 hours, that's 3 days, in the absence of signs of the strangulation or peritonitis. If there is the same protocol, if there is a sign of this peritonitis, it needs surgery as such. Then open surgery is used for the strangulating obstructions, whereas for the non-strangulating obstruction, now these days laparoscopic approach also is preferred. Then hyaluronic acid or carboxycellulose membrane, it reduces the adhesions in the obstruction. Injection of this hyaluronic acid also is often tried. It is one of the current approach. Prediction of the prognosis of an obstruction is also done by assessing the location of the obstruction and grading them. Now, grading of the obstruction is based upon whether there is a real adhesion or that it's a filmy adhesion. This is particularly intraoperative grading. Once you have opened the abdomen and obstructions, if this is simple, smooth and filmy and can be separated with the blunt resection, then it's graded as 1. Strong adhesions 2, and very strong vascularized adhesions which requires a sharp dissection is graded as 3. Then regions of the abdomen is A to E classified in the same, and these are graded. Now this grading would be quite useful to predict the outcome. Higher the grade, chances of recurrence of the obstruction are more, and the patient may have to be warned about. Now, confirmation of the obstruction by the or adhesions by the CT image. CT image shows that loops of the intestines which are adhere, or the intestinal loop which is adhere to the umbilical area. Of course, this is a case of a patient who had undergone laparoscopy earlier, and that the port opening, laparoscopy is port opening, at that area the loop had become adhered and that had produced the obstruction. So that's the CT image that helps you to locate the obstruction. Plain X-rays is always better to have a water soluble radio opaque substance X-ray to confirm whether the obstruction is located or not. So for the plain X-ray, it's not barium soluble. Barium, because it's water insoluble, it's not preferred, because barium swallow X-ray often can result in aggravation of the obstruction. So you will have to prefer so water soluble substance like sodium iodothalamate, the same substance which you use for intravenous radio opacity or that contrast can be given orally, and you have to follow up, and the location of the obstruction and progression of lesions can be seen. One of the general guidelines is if the dye reaches the colon within 48 hours, then that condition may not require surgery. If it fails to reach the colon by 48 hours, then it may be a condition which may require surgery. That's the other way. So the general paradigm or logarithm of treating the patients of obstruction induced the intestinal adhesion induced intestinal obstruction, adhesion induced intestinal obstruction is a same which we have discussed. Whether the obstruction is confirmed or not. If we are sure about the obstruction, CTs can be bypassed. If we are not sure, CT is the one which to confirm the obstruction. And then if the patient doesn't have a sign of strangulation or sign of peritonitis, then you have to manage or observe the patient or see whether progression of the obstruction by water soluble contrast imaging, which gives you an idea like whether the obstruction is getting relieved or not, or whether the obstruction may be relieved or not. And you may have to continue with the non-operative. The same issue, non-operative management would be nil per mouth and IV fluids and nasogastric drainage. That's the issue. And then if it is producing any complications, then surgical exploration would be required. In the surgical exploration, again, is the general trend now. Current trend is attempt for the laparoscopy when you have a sufficient experience and the patient has a lesser area of obstruction, or the grade of the adhesion is lower. If the grade of adhesion is higher, then open surgery is better. In any of the patients who have undergone abdominal surgeries, the possible this occurring of the adhesions is quite difficult to predict, and these days currently very recently there has been a practice of using addition barriers after laparotomy. For any other reason, if the abdomen is open, use of these addition barriers now is becoming popular with an idea of preventing the possibility of the additions. And these substances are, which are now approved and they are used are hyaluronate carboxymethyl cellulose or oxidized cellulose or icodextrin or polyethylene glycol, and they are now available and there's a practice of using them. Their clinical efficacy isn't particularly hyaluronate carboxymethylose is considered to be having high potential or high capacity, 95% accuracy, and relatively risk being lower as 0.49%. The others, of course, have a relative this risk issue, and only the other difference will be the cost difference. So that's about the addition-induced obstruction. The next thing which we discuss would be the intersusception resulting in the obstruction. The intersusception means that a loop of intestine gets projected into another loop of the intestine, and usually it's proximal to the distal. But very rarely there could be a reverse. A distal loop may even get into the proximal loop. And at this situation, you will have a loop of intestine within the other loop of the intestine, and at one level there would be 4 layers of the intestines at the same plane, and this plane is this projected mass is called as intersusceptions, and that space is intersusceptions, and this is what called as the intersusceptum. The projecting loop is called as intersusceptum. Now, the loop of the intestine which is compressed, or you have that location where there are 4 holes, is the situation or is the location where the strangulation occurs early. This is a very important issue. When you open the abdomen in a case of intersusception, this ischemic loop may not be visible till you have reduced the intersection. It looks like the loops are healthy otherwise. Only when they are pulled out, this loop seems to be that necrotic or maybe strangulated, and hence that has to be very careful. Cause for the intersusception are not so well defined, but it's always suggested that due to some momentum, particularly if the lymph nodes or the lymphatic tissue in the loop of intestine has become swollen, and because it increases the gravity during the peristalsis, that area where the gravity is more, it may get projected into the loop, and that once it gets into the loop, it may get projected continuously depending upon the strength of the peristalsis and the other factors. At times, this loop, intersusceptum loop, could be very long, and it could be even projected through the anus and may produce a confusion with the prolapse of the rectum. So that's a very rare situation, but it also can occur occasionally. The projection could be from the ileum to the up to the rectum. It can occur rarely. Such conditions also are reported. So cause is supposed to be some mechanical issue. So, either it could be a tumor or it could be a lymphoid tissue which has become inflamed. In children, particularly in certain seasons, like the seasons when the cold is more, the incidence of intersusception also is more. The reason is simple. During the cold season, the sputum or maybe the phlegm from the respiratory tract would be swallowed into the gastrointestinal tract, and that phlegm would carry the bacterial organisms which can produce a reaction in the lymphatic tissue of the intestines, and hence the intersusception is commonly seen in the seasons when the cold is more, particularly in children. Depending upon the involvement of the loop, the intersusception may be classified as enteroenteral, jejunal, jejunal-ileal, or ilio-ileal, or ileocecal, or retrograde. The otherwise is the retrograde. That's all simply like whether it's a loop of colon to the colon, or loop of jejunum to the jejunum, or jejunum to the ileum, and so on. That's all the issue. Clinical symptoms are vomiting is seen early, initially, and it's initially non-bilious and reflexive, and when the obstruction occurs, it becomes more bilious gradually. Pain is colicky and severe and intermittent. Passage of the blood and mucus in the stools is characteristic, till very advanced stages, patient may not have a obstipation. Constipation is rather absent. Patient may continue to pass the stools, or many times it can have a diarrhea-like condition, and sloughed mucosa is with the blood, and this appearance is often named as red currant jelly like stools. Patient may be lethargic because of in the can be the simple, particularly in children, the child may become lethargic. Child may not complain of more pain in some cases. Abdominal mass is palpated. Abdominal mass of the intersected loop can be palpated. At the same time, the area from where that loop is shifted may become empty. Particularly, the incidence of ileocecal this intersection is more, and in such conditions, right iliac fossa would be empty. That's the characteristic feature. Confirmation of the intersection is better done by CT scan, where this projection can be easily made out. In the otherwise, barium minima is indicated. Barium minima in a case of intestinal obstruction is indicated, and in that condition you have that dog ear-like appearance. The barium minima, which is pushed from the distal side, it will reach up to the loop, and the intersection space, the barium is filled up, and it gives a dog ear-like appearance. This is the characteristic sign which used to be there before the popularity of the CT scan. So barium minima was more dependable. Now CT scanning is more dependable. Or simply plain X-ray also occasionally may show the loop of the intestines. It's a very rare situation. In a very high quality plain X-ray, you may be able to see that loop of the intestine which has projected in and produced the obstruction. See, USG also can help you, but high resolution USG can locate the area, as well as with the USG, the advantage is the vascularity of the loop also can be made out. As I told you, in a case of intersection, when you open the abdomen, the loop of intestine may look to be healthy, but as you pull out the loop, you will have the problem. The strangulation may be seen. And the method of reduction would be now, currently it's always preferable to have a non-operative approach if you have confirmed the obstruction, this intersection. The practically conservative management is preferred. Conservative management is the same as we have discussed earlier, nil orally and IV fluids. Then it's attempted to reduce the intersection by either a hydrostatic pressure, where a barium enema or the water soluble contrast enema is given, and with that enema, force of the enema, the loop which has projected in may be pushed back, and hence it may get removed. Or now another technique which has developed, which is becoming popular, is a pneumatic obstruction, where you have a specific instrument where the air could be injected in, and due to the pressure of the air, it may just get reduced. But if these treatments fail, then immediate surgery is required, because this pressure may produce either perforation or the strangulation. Then another variation or cause for the obstruction is volvulus. Volvulus is twisting of the loop of the intestine. The twisting of the loop of the intestine can occur anywhere, but the incidence is more common in the sigmoid. So, as far as the practical situations are concerned, volvulus is always related to the sigmoid colon conditions, though rarely volvulus can occur elsewhere too. Even in the stomach, volvulus can occur, rarely they are reported. So, but for practical clinical purposes, we discuss volvulus as the large intestinal obstruction cause, and in the sigmoid colon area. Because of the loop gets twisted out, that loop becomes distended with the gas, and proximally it produces the same obstruction. So clinical identification would be, occasionally you may do a parectal examination. Parectal examination would show dilatation of the rectum, and the X-rays will show you the loop of the intestines which are dilated, and the patient will present with the typically distal intestinal obstruction symptoms. Confirmation can be done by USG or CT, which can show you the level better. In a plain X-ray, you may see that the loop, which is significantly dilated, as a separate entity as such. The treatment would be based upon the course. There could be two presentations: colonic volvulus, which is sigmoid colon, that's as I said, the distal portion where the stool contents are solid, and hence the chances of the complications are more. Whereas in case of the cecal proximal side, the chances of a complication are lesser. So conditions in all these conditions, surgical exploration is always better than conservative treatment. Trying to reduce the volus externally by manipulation on the external side has become successful, or at times endoscopic decompression, attempting to reduce the walls by endoscopy, either colonoscope or maybe the gastroscope, have been successful occasionally, but the right step would be exploratory laparotomy, where the loop has to be examined, viability of the loop has to be confirmed, either it has to be ended in resection and maybe colostomy, or simply reduction and fixing that loop of the colon into the extraperitoneal area, or extraperitonealization of the loop of the intestine, so that it doesn't recur. Now, another cause for the this obstruction, common in our area, could be worms, Ascariasis worms. We had that kind of a patient in 89, and this is a patient who was operated here only. And in that condition, a large amount of the worms, particularly patients, children who are prone for the worms, and when they are given antihelminthic drugs, these antihelminthic drugs can be the triggering factor for the worm balls. Worms which are getting mobilized, they may produce a ball-like situation and they produce a clinical obstruction. When you open the abdomen, you may see that. That's about the general issues and the certain of the common causes of the obstruction which are seen. Then the next variation of the obstruction is the large intestinal obstruction. Large intestinal obstruction is considered as a high risk condition, and hence it is categorized as a can't miss gastrointestinal diagnosis. That diagnosis should not be missed, and early diagnosis is the most important criteria in case of the large intestinal obstruction. Of course, the causes for the large intestinal obstructions are the same as that of the small intestinal obstruction. The clinical symptoms will be abdominal distension, nausea, vomiting, crampy abdominal pain, and abrupt onset of the symptoms make an acute obstructive event. Shorter the course of the onset of the symptoms, it could be like a volvulus or cecal volvulus or sigmoid volvulus, and they are more likely diagnosis. The important is the patients who have a history of long-term cathartic use, that's use of purgatives regularly, and continuous training for the stools also may be a cause for the obstruction, or which could be suggestive of diverticulitis or carcinoma. Diverticulitis is another cause for the large intestinal obstruction. The risk of perforation is quite high, particularly if the obstruction is in the distal portion, and this produces what we call as a closed loop. See, intestinal obstruction, large intestinal obstruction, when it becomes distended, the proximal loop is distended, the ileocecal wall may not open, and hence the distension may not spread into the ileum. It may limit to the colon only, and hence the pressure built up in the colon could be high, and it can result in a early perforation. Risk of perforation is quite high, and if it gets perforated in the colon, the severity of the peritonitis also would be quite high, because the contents are fecal contents, which can produce more serious complications. And because of that situation where the loop, ileocecal valve may get closed, and the distension occurs in that closed loop, it's also called as closed loop syndrome. The other name given there is the closed loop syndrome, and that has to be taken care of. The issue is the diagnosis has to be made by the plain X-ray as usual. In the same issue, management, the fluid resuscitation, antibiotics, nasogastric and flatus tubes are often tried. Flatus tubes have a significance. Some of the patients may be relieved by the flatus tubes, but as far as the general management is concerned, exploratory laparotomy is always preferred as the choice of the protocol in case of the management of the distal intestinal obstruction. The last part will be the paralytic ileus or pseudo obstruction. The paralytic ileus is a very common event after any abdominal surgery, but usually it's limited for 24 hours to 48 hours, and the patient should recover. If the patient doesn't recover from the paralytic ileus stage after the abdominal surgery, then you have to think of the possible causes and then review the patient. So, having a paralytic ileus symptom or not being able to pass the platus up to 24 hours or 48 hours after an abdominal surgery is a common phenomenon. Paralytic ileus also could be produced due to the diseases like peritonitis, appendicitis, cholecystitis, and so on, or ischemic conditions, infections, drugs, and electrolyte and metabolic abnormalities. Drugs which can produce the paralytic ileus are opioids, particularly loperamide, which is used for as a treatment for the diarrhea. Many times the loperamide is sold in the open market, and people have a habit of consuming loperamide the moment they have one episode of diarrhea also. It is one of the causes for the paralytic ileus. Remember that. Calcium channel blockers, clonidine antihypertensive drug, alpha-adrenergic medications, all sorts of that alpha-adrenergic medications which are used in the ischemic disorders, and anticholinergic property drugs like antipsychotics, antihistamines, muscle relaxants, Parkinson drugs, as well as hypokalemia, hyponatremia, hypomagnesemia, hypothyroidism, hyperglycemia, uremia is the other causes for the paralytic ileus conditions. Once you have made the diagnosis of paralytic ileus condition, the initial management will be the same: nasogastric tube, IV fluids, electrolytes, and the patient has to be mobilized as far as possible. Surgery is generally not preferred unless there is a significant indication like perforation, so on. Then certain specific medications are now used depending upon the causes. Erythromycin initially was believed to be one of the drugs which can stimulate the peristalsis, and paralytic ileus could be managed. But now the role is questioned. It's a questionable role, but still there is a practice of prescribing erythromycin in case of paralytic ileus. Methyl naltrexone is preferred in case of post-operative paralytic ileus, particularly if the patient doesn't recover even after 48 hours. But whenever you use these drugs, you have to be sure that the patient doesn't have any distal obstruction. In a patient with distal obstruction, if you give that stimulant drugs, particularly vacanical or neostigmine, there will be a high risk of perforation, and that because of that the practice now has become obsolete. Earlier we used to use these drugs for more common. Opioid drug-induced paralytic ileus, again methyl naltrexone is the drug of choice in such conditions, which may help in recovery. So that's about the paralytic ileus, and with this we conclude today. That concludes about the intestinal obstruction. The next we will discuss about the perforation, and we'll try to see if there are any questions and then wind up. Right, there are no questions. We'll wind up. Thank you.